Dr. Milan. Dr. Milan, one of the oculoplastic surgery pioneers of oculoplastic surgery in India in LV Prasad Eye Hospital. Today he speak about lid reconstruction, and Dr. Samer Kharma from Jordan, one of the best oculoplastic surgeons in Jordan. First of thing, are my sound is okay or not?
Your sound is perfect.
Okay, nice. Now we can start now or after 2 to 3 minutes.
I can see Dr. Samir is still driving.
Yes, Samer is still driving.
Drive safe.
Dr. Samer.
Let Dr. Milan start and Dr. Samer will join. Not now,
Yes.
no problem.
Yes, no problem.
Start
Yes.
your presentation, Dr. Milan. You can.
Yes.
Shall I start sharing the screen?
Yes.
Okay, great. Okay, good evening, everyone. I hope I'm audible. Tariq?
Yes, yes, your sound's clear.
Okay. Thanks to Tariq and Dr. Samir and the colleagues in Yemen as well as Jordan and some of our Indian colleagues who are here to attend the webinar. This is a picture from the year 2018, I guess, where Tariq was with us at LV Prasad Eye Institute. He spent 3 wonderful months, worked with us in the clinics, joined all the parties, and even published with us. And
Yes,
we're really proud that Tariq is now doing good work back home. And it's a pleasure to participate in any of your events, Tariq. So with that brief introduction, we'll start off with eyelid reconstruction, and I will just touch up on a few tips and tricks in this field and how I personally go about thinking in terms of eyelid reconstruction. So the indications are very obvious. Either you have congenital colobomas or you have acute trauma where there is tissue loss. Sometimes there could be disorganized tissue rather than real loss, and tumors. So these are the prime indications where reconstruction is required. And to understand the goals of reconstruction is very important because sometimes we tend to forget the focus. First goal of any reconstruction is to adequately cover the eyeball. Second is a good eyelid contour and height, then to have a non-irritating eyelid. And lastly comes function as well as color match, which is more of a cosmetic stuff. Now between the two eyelids, on the left, you see a man whose lower eyelid is lost a couple of weeks ago, but he's still having a good cornea because his upper eyelid can maintain tear film. And on the right is a man who has lost primarily his upper eyelid, and his cornea is entirely dry. So between the two, it's always an emergency to manage upper eyelid tissue loss than lower eyelid. And whenever you think of eyelid reconstructions, always think in terms of the posterior lamella and the anterior lamella. You have to restore both whenever they are missing. But sometimes you may have only one of these components missing, and we'll go over some examples. So either a patient could just have a posterior lamellar pathology or an anterior lamellar pathology, or it could be just a marginal lesion. And it could be a full thickness lesion where you will have a full thickness defect. Posterior lamellar pathologies are rare. Here there is an epidermoid cyst of the tarsus, and we just excised it from the posterior lamella, leaving the anterior lamella untouched. And that is what is an easy option in these cases. There is another variety which is called as marginal lesions, and they would be sitting right at the eyelid margin. If it's a benign lesion, you could do what is called as a shave biopsy, but there is a theoretical risk of losing some of the lashes. So here you have a choice between shave biopsy and doing a pentagon excision. And then there are certain lesions which are entirely only anterior lamella, like this nevus or the basal cell carcinoma, a small little uh, benign lesion here, or a papilloma. This is a basal cell carcinoma, which is pigmented. So these are all anterior lamellar lesions where posterior lamella might be left alone. Talking about anterior lamellar defects, you can either, you have a variety of options available, and we'll just go over them quickly. So lesions which are near the canthi, or the ones which involve the eyelid, but they are less than 5 millimeters, you can just leave them to granulate, as is seen in this picture, and they heal quite well. Here is another example of a small papilloma, which was just left in place to granulate, and it healed well. As against that, a larger excision, more than 5 millimeters, would require a skin graft in that area, like this particular lady. For full thickness lesions, anything that is 1/3 or less of the horizontal dimension of the eyelid, we can plan a direct closure, or we can add a canthotomy and cantholysis to it. Anything that is between 1/3 to half, we can plan a Tenzel's flap or a sliding tarsal graft, and this whole thing is a spectrum. Lesions which are leading to a loss of more than half of the eyelid will require a cutler beard flap or any kind of combination flaps when the lesions are larger than that. And we'll talk about some of these examples towards the end. So talking about small defect, less than 1/3, you have to look at what's the size of the lesion, location, and configuration. Usually the defect looks larger than what you initially excised because the tissue stretches, but you need to approximate the edges and see whether there is approximation without tension. If they touch without too much of tension, then you don't need a canthotomy and cantholysis. Here is a pentagon marked along a marginal lesion. So the marginal part is done with a 15 number blade. The skin marking is done either with blade or monopolar cautery. And the rest of the full thickness eyelid can be cut out with scissors. A Stevens, which is straight, can be used, or you can also use a monopolar cautery. So that's the defect, looking larger than your initial marked pentagon, and you're trying to approximate the edges. In cases where it's not approximating fully, you have to do what is called as canthotomy and cantholysis. Canthotomy only separates the two limbs of the lateral canthal tendon, as you see here. Cantholysis is releasing one of them. So cantholysis can either be inferior or superior. In this case, we did an inferior cantholysis so that the edges could approximate. Now the marginal closure is done with a 6/0 silk, or you can also use Vicryl, but it has to pass not through the gray line, but through the tough structure of the eyelid, which is the tarsus. So here we are taking a marginal suture, and this is a vertical mattress suture. So you go equidistant on the eyelid margin as well as the cut margin. And there is a far and near loop to the suture. And once you've taken the marginal suture, then you can add 1 or 2 more to the tarsus. These will be buried Vicryl sutures, then the orbicularis, and finally the skin. So that's a primary closure. This is just an example of a small little coloboma in a child, which was treated with a primary closure. Here is another example of a small traumatic notch treated with primary closure. Sometimes marginal lesions where the patient is not ready to accept lash loss might require a pentagon excision, although it is benign. And this is one of those cases. You can see a small little vertical mark on the eyelid and down gaze postoperatively. For moderate defects, which are 1/3 to half, the standard procedure is tensils or temporal advancement, or you can also do a sliding tarsal flap, which we'll discuss. Tensils is nothing but where you are unable to approximate the edges of a pentagon excision. You take a semicircular flap beyond the lateral canthus, such that you move the posterior lamella as well as bring in extra anterior lamella to close the defect. So here was a sebaceous gland carcinoma of the upper eyelid. We marked the pentagon, we've excised that, and you can see that even with stretching the edges, it's not approximating. So here a canthotomy cantholysis may not have helped. That is what was the judgment on table, and that's why we took this semicircular flap, which goes skin and muscle deep. And while the flap is raised, you also release the lateral superior crus of the lateral canthal tendon so that the flap moves medial. So once you've done that, the edges can be approximated easily. Then we close it similar to what we did earlier, like a standard closure. And that is how it looks at the end of the procedure. So you have a semicircular flap. This flap extends from the lateral canthus, it comes down, and you can fashion it based on the amount of requirement of the skin. And there are no critical arithmetic or geometry involved in these flaps. For the first couple of days, the eye will be closed due to the horizontal tension, but it gradually opens up. So that is a tensils semicircular flap. This is an example of the same being used in a kid with a coloboma, which is slightly larger than what could have been managed with primary closure. One more flap I'll discuss for moderate defects. This is a patient with a sebaceous gland carcinoma upper eyelid. We excised that, and you can see that there is a certain length of this defect, which is around 1/3 to 1/2. So what we are doing is everting the eyelid using the remaining tarsus. We leave the 4 mm from the margin. We make a horizontal incision and then a vertical incision, as you can see here. And we raise this flap. This entire flap is now raised, but it is hinged in the fornix. And now you move this flap into that defect and suture it in place. So posteriorly, on the lateral half, you will have a raw area, but that will be epithelialized by the conjunctiva. So here we put the posterior lamella in place, and then the anterior lamella here we covered with a combination of flap and skin graft, but you could directly use a skin graft. So here is the patient couple of weeks after the surgery. You can see there's a little bit of lid lag and down gaze, but this tarsus is well replaced from the lateral half. Full thickness large defects, the standard procedure is the Cutler beard, and I'll quickly go through the steps of that procedure here. This is a large sebaceous gland carcinoma. After excision, you've literally lost 2/3 of the upper eyelid. So this is a lid shearing procedure where you take a flap below the lower edge of the lower eyelid tarsus. You mark the vertical cuts. This is a full thickness flap which goes under the bridge of the eyelid margin. You split it between posterior and anterior lamella, and then you suture it into the defect. 6 weeks later, you release this band so that the upper eyelid gets more tissue from the lower eyelid, and you have a separation. Then you repair the wound in the lower eyelid. So this is a 2-stage procedure spanning over 6 to 8 weeks. This is a lady who had sebaceous gland carcinoma of the upper eyelid, and this is after her Cutler beard, waiting for the stage 2. And this is a couple of weeks after the stage 2. As you can see, the cosmesis is acceptable, and functionally the eyelid can close well. You can also use Cutler beard for eccentric lesions, lateral or medial. The idea is to keep your flap always centrally placed, whether your defect is lateral, medial, or central. Very rarely, large upper eyelid congenital colomomas have to be treated with lid shearing procedure, despite the risk of amblyopia. I'm going to go over a couple of other procedures that are often used as a part of lid reconstruction. Here is a lady with right lower eyelid marginal basal cell carcinoma, loss of lashes, as you can see here. That was the excision area. It was going to lose the canthus as well as part of the upper eyelid with a 4 mm margin. So we excised all that. Margin clearance was done intraoperatively, and what we were left with is marginal tissue loss in the lower eyelid. So what we did was we raised a periosteal flap laterally. So that is the periosteal flap coming there. Then we raised a Hughes flap from the upper eyelid, which is open-ended laterally. So periosteal flap and Hughes flap forms the posterior lamella. And for the anterior lamella, we just borrowed a monopedicle flap from the upper eyelid, which is now in place. And the lower part can always be covered with a skin graft if required. But in this case, just the flap was enough. So that is how she was for a couple of weeks. Then we released the two, that is the Hughes flap separation. And this is how she looks couple of weeks after the stage 2. Not perfect, but functionally she is doing well and tumor-free. Another similar example, lateral 2/3 of the eyelid canthus, also part of the upper eyelid. Similar procedure. This is the periosteal flap. Hughes flap coming from the upper eyelid, as you can see in these pictures. That's periosteal flap, that's Hughes flap. And for the skin, we took what is called as a Frick flap here. Here is a patient with complete lower eyelid loss. We waited for the first 3 months and then Hughes flap along with skin graft. He is not perfect. The lower is still a little ectropic, but we are still okay functionally. Tariq, we have some time.
Yes, we have sometimes, yes.
Okay, I'm just going to go over a couple of complex cases where the defects are large. This is a large basal cell carcinoma involving the lower eyelid. So you can see that the excision here would be vertically wide as well as horizontally wide. So total loss right up to the fornix, only a small stump of lower eyelid remaining medially. And even the vertical depth of this anterior lamellar flap is huge. So what options do we have here? Laterally, we again raised a periosteal flap. Then we took a Hughes flap from the upper eyelid. So that formed our posterior lamella, as you can see here. And then for the anterior lamella, there are multiple options. You can take a monopedicle flap from the upper eyelid. You can take a Frick flap. But what we chose was a combination of monopedicle and skin graft from the pre-auricular area. So this is how he looked a couple of days after the skin grafting. That is while his Hughes flap is still in place. This is 1 week after release of Hughes flap, and this is 6 weeks. Again, not looking perfect, but functionally fine. A huge sebaceous gland carcinoma involving the entire lower eyelid medial canthal area. But this was not really meant for exentration because if you look at the scans, it was mainly preceptal. So we decided to excise this. This is the huge defect that was created. This is your anterior lacrimal crest. We also had to do a dacryocystectomy in this particular case. So here, posterior lamella, again, the plan was the same, taking a Hughes flap. We already had a lateral stump of the eyelid. But for the large anterior lamella, we decided to choose a midline forehead flap. So it is hinged at the glabella. So this flap is going to turn into your anterior lamellar defect. The base is sutured back. And this is how he would look on table. Obviously, there will be a hump on the nose, which will have to be flattened in stage 2. When we put the flap into the skin area, we do what is called as defatting so that it matches the thickness of the eyelid skin. This is how he looked 6 weeks after the stage 1. In stage 2, we do a release of the Hughes, which is done in a layered manner. The conjunctival flap is left slightly larger. And we suture back the lower eyelid margin. And we also revise this hump on the nose to make it look normal. So this is the final stage, preoperative, intraoperative defect. This is immediately day 1 after the stage 1 surgery. This is before the Hughes release, and this is 2 to 3 months after the stage 2. Here is another superomedial basal cell carcinoma. That is a large defect. So just a cutler beard was unlikely to help. So we combined that with a small little glabellar flap, which was just put down and sutured in place. So here is she, couple of months post-surgery, functionally doing well. Another medial canthal BCC, and in these areas where you have a large defect in the medial canthal region, you can often do a flap along the nasolabial fold and just push it upwards to cover the defect. So that's what we did in this case. And this is a relatively early post-operative picture, but she's doing fine functionally. Another case of a large sebaceous gland carcinoma involving the lateral half of the upper eyelid. We did an excision. As you can see here, the canthus is lost. Part of the lateral eyelid was lost. And what was done in this case was we took a periosteal flap. Then we took a sliding tarsal graft from the remaining medial eyelid, and we rearranged the anterior lamellar skin without really doing a graft. So this is how she looks couple of weeks post second stage. And you can see that the anterior lamella is actually short, but functionally she is fine. So I'll stop here, and what we covered is the basics of eyelid reconstruction, posterior lamella, anterior lamella, full thickness. In full thickness, it was primary closure, tensils, and Hughes flap, as well as cutler beard. And we looked at some examples of more extensive flap reconstructions. Thank you.
Thank you, Dr. Milan, for this interesting lectures. Now we can receive any question for these lectures. Only raise hand or can write in chat. Or postpone the discussion after Dr. Samer lectures.
Sure.
Okay. Dr. Samer.
Hello, yes, Dr. Tariq, listening.
Yes.
Hello there.
Yes.
Hello.
I'm back home. I'm back home, thanks God, within time. Can you hear me well?
Yes.
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 Dr. Milan, this was a really beautiful presentation. We learned so much from it. It was really comprehensive and really very much tells us the basics of beautiful reconstruction. Tariq, I must congratulate you for choosing such a beautiful, wonderful teacher.
Oh, thank you.
Okay, now you have to close your slides probably so that I can start. Okay, I will talk about a little bit different topic, in fact. Away from the eyelids, I will talk about the orbit injuries and how to reconstruct the orbital bone injuries. In fact, this is a problem in practice, especially with our juniors who always have difficulty in managing orbital injuries because they have the fear of where we start and where we stop. The orbits are, as you know, conical, four-sided pyramidal, which open points back into the head. Each orbit consists of a base, an apex, and four walls. The orbit is intended to protect the eye from mechanical injuries. The bones of the orbit, I will not go through the basic anatomy, but for anybody who's managing orbital injuries, he has to remember the bones of within the orbit.
دكتور سامر بعد إذن حضرتك بدأ الصوت يقطع.
اتكلم الآن دكتور سامر.
لا مش باين إن في سيجنال بتاعت كلام، بس هو في مشكلة عنده.
So this is the bony cavity around the globe and the muscles, and we have neighbors. We have to respect our neighbors in life and in medicine. Our neighbors are the brain and the sinuses. This is the complex anatomy of the orbit. I wonder and feel surprised how non-oculoplastic surgeons and non-ophthalmologists, how do they dare to operate within this complex area in the globe and the muscles and the nerves. So these are the neighbors, the brain and the sinuses. In general, as a basic rule for orbital injury assessment in any patient who has was received in the emergency room, you have to work according to priorities. When we were juniors in general hospitals, we were always in trouble. People want to push the patient to our beds, while the patient might be having something more serious than ophthalmic problem. So talking to my juniors, we have to organize our priorities, talking about, first of all, rule out life-threatening problems like abdominal injury, chest injury, brain injury, then go to the ophthalmic injury. And when you go to the ophthalmic injury also, make sure that the most vital structure of the orbit, that is the globe, is intact, and it didn't sustain any sort of penetrating injury or a blunt injury, which might really affect the subsequent visual outcome, and you end in a medical legal issue, or that you are doing orbital fracture repair and you forgot to take care of the vital structure within the orbit, that's the globe. Manifestations of orbital injuries can manifest in one of the following scenarios. It can be a fracture, it can be a retained foreign body, it can be a retained orbitocranial injury, or it can be an optic nerve injury. The most common and the most frequent thing we, as oculoplastic surgeons, we face when we're talking about fractures is the orbital floor fracture. I keep telling my residents, when you are suspecting orbital floor injury, from history, you have to ask the patient certain things in history to realize whether he has a fracture or not. By asking him, sir, did you have any epistaxis? Did you have any nasal bleeding? A gentleman who developed an orbital injury by a fist or by a ball or so. Did you have bleeding from your nose? This tells you whether there's a floor or medial wall fracture. Sir, do you have double vision? Then whether he has numbness over the cheek, the infraorbital area distribution. This is a traditional classic scenario for pure blowout fracture. I mean by pure, we have to use this term pure when the orbital rim is intact. That's when the orbital rims are intact and yet you get a fracture. That's what we call as blowout fracture. The orbital orifice has received a huge force which has obliterated the outlet of the orbit. So the globe decompresses itself. Instead of rupturing, it decompresses itself by breaking the thin bonds of the floor and medial wall. This is what we call as blowout fracture. Blowout fracture, usually it can even present with proptosis, in fact, in the early phase. But as edema resolves, the enophthalmos starts to appear, And the double diplopia, you can see the limitation in up gaze, which means that you might be having an entrapped inferior rectus. You can see there's a classical right-sided blowout fracture, huge fracture. There is always this is called the teardrop sign. There's always a debate on when to operate and when not to operate in orbital floor fractures. The critical factors which make the indication usually are the size of the fracture. Such a huge fracture will almost never escape without repair, because you will end with huge inophtalmus, as you have the orbit has expanded so much, and you might have great amount of double vision if you don't repair such a huge fracture. So the size of the fracture is an indication. The persistent diplopia after 2 weeks, and then if there is inophtalmus. The fourth indication, which I would like to talk about, I will come in a minute. This is the HIS chart. This chart maybe is now out of date. Nobody's doing his chart. It used to be a golden tool to make the diagnosis of whether there is restriction or not. As we learned as residents, the area with the smaller field is the defective area. So this is the area of the injury, and there's limitation of up gaze and down gaze, and here the neurological compensation. Maybe nobody does his chart anymore. The last indication of repair of medial, of a floor fracture, which I did not mention, is the trapdoor fracture, where we have a white orbit. A child develops an injury to the orbit, and there is herniation, small amount of herniation usually within the orbit, but it gives him a big vagal stimulation, nausea, and even bradycardia, and you have to repair this trapdoor fracture usually quickly, because the muscle otherwise will be ischemic, and the child will suffer a lot while his vagal nerve is playing. Going to the medial wall fracture is a less common fracture. It's usually it might be isolated or in association with floor fracture. Diplopia can happen, but it's less. It's usually when an abduction. Indication of repair of medial wall fracture, which we do it quite often, in fact, when there is intractable double vision or when there is inophtalmus, and we see this even after medial wall fractures. You see, this gentleman has a left-sided medial wall fracture. He's trying to look to the left. You can see his globe is tethered and it's not moving to the left. So you need to operate. Lateral wall fracture. The lateral wall of the orbit is, in fact, it's the strongest wall, and it's very well. It's a thick wall. It's well supported by temporalis. It is the least to get fractured. It would get fractured only in very huge injuries, very huge road traffic accidents. Usually, we don't operate on lateral wall fractures alone, because usually we need the help of our maxillofacial colleagues, because the fracture is usually tremendous and involves the zygoma. Orbital roof fracture, by definition, is a neurosurgical problem, because the dura and the brain is just in the top of the fracture. You cannot repair the fracture alone. You have to cooperate with your neurosurgical colleague. If the fracture in the roof is very big, you can even see pulsation from the globe, which is the conducted dural pulsation. This is usually, as I told you, needs a neurosurgical intervention. I will not talk a lot about the eyelid injuries, in fact. But I want to say that when you have an orbital injury, remember that there could be, as you can see, ruptured globe. Don't rush into doing bone work and ignoring the sight-threatening problems. You might be having hyphema, traumatic rosette cataract, lens subluxation. You can be having a retinal posterior segment, serious tears, or even optic neuropathy. All this has to be settled out medical legally before we talk about fracture repair. Penetrating orbital injuries, as I said, there might be entrapped, the retained intraocular foreign body. This child was playing with his brother, and his brother managed to give him this bullet inside his the roof of the orbit. At the time of X-rays, this is maybe 15 years ago. We did nothing because this is an inert material. We just give him antibiotic, and with the trying to remove the foreign body is sometimes more harmful and risky than leaving it alone. This is the child after a couple of weeks of medical treatment. We don't run after every foreign body inside the orbit. We don't fish for them. If it is an inert material, not of vegetable origin, or not causing a serious threat to the optic nerve, for example, or something like that, we leave it alone. That's all what I had to say. I welcome any questions or comments. Thank you very much.
Thank you, Dr. Samer, for this nice lectures. We can receive questions by raise hand or write on the chat downward. I want to ask Dr. Miland.
Dr. Samer.
Yes, sir.
This was a wonderful summary of orbital trauma. I just wanted to ask whether in your country or in your practice, it is the plastic surgeon or the maxillofacial surgeon who takes care of trauma primarily, and how commonly do you all work together?
Thank you, Milan. Thank you for your beautiful comment and for your wonderful, very practical question. In general, when we have a multi-injured patient, Milan, in our country, the patient is hospitalized under the surgical beds, in fact, when he's multi-traumatized, because the general surgeon has to take care of his general health. If the problem is limited just to the orbit, after making sure that the globe is intact, then we go to the bone business. When we are talking about pure floor or pure medial wall fractures, usually we as oculoplastic surgeons do them alone. And as you know, Milan, this is our area. We know the anatomy well. We know the pathologies well. We know how to insert the mesh, where and how, and we know it more than the maxillofacial or the plastic surgeons. But to be frank and to be fair, when you have a complex orbital injury with the orbital rim involvement, maxilla involvement, zygoma involvement, it's unfair to do it without taking the help of our maxillofacial colleagues.
Absolutely.
In my career, Milan, I have learned so much from my colleagues in the neighboring specialties like maxillofacial, ENT, neurosurgeons. I'm sure you have the similar experience with your colleagues. So each one of us should know where his area is and where to involve others.
Very well said. Thank you.
Thank you, Milan.
In our country, due to the war, most of cases, complex cases, maxillo, orbit, very difficult to do oculoplastic alone. We can shearing with maxillofacial.
Absolutely.
Yeah, that's a pity. That's a pity, unfortunately.
Well, I would like to suggest to the audience who's here to also try and go through the AOCMF website and also try and become a member, because that's a multi-speciality group which conducts very high-class training modules. And as an oculoplastic surgeon, I've benefited immensely by being a part of that group. And if anyone wants any information, I'll be happy to share.
Can you give us the link again, Milan?
Yes.
Yeah, I'll just type the website here.
Please, thank you.
It's ACC. Okay.
That's for what?
That's a multi-speciality group, which the CMF part is just the craniomaxillofacial surgeons, and a lot of oculoplastic surgeons are a part of this team, and I am a faculty on that group myself, and it's real good interaction between specialties. They also have a Facebook page which you can log in and just learn from the case discussions. There's a website. There are 2 journals which are PubMed indexed. So it's a very useful team to be with.
Thank you. Well, Milan, can I ask you, what's your personal practice in orbital floor fracture? Do you do them transcon or subciliary? And what do you use as a spacer?
Well, I use a transconjunctival approach as default, especially when there's a pure floor fracture. In cases where the rim is involved and the maxillofacial surgeon needs to put plates and screws around the orbital rim, they usually prefer a subciliary so that we can get to those anatomic areas better. And I use everything from titanium mesh to absorbable materials to Forex to X-ray sheet. It all depends on the financial status. Our hospital provides a spectrum of packages for the patient based on their affordability. And much of our work is done free of cost. Tariq knows it very well. And yes, so the choice is, it's a spectrum available for me.
Yeah, thank you. Excellent. Thank you, Milan.
Okay, Dr. Milan, do you prefer vicryl sutures or nylon in eyelid with the best for cosmetic?
Can you come again?
Do you prefer vicryl type of sutures?
Oh yes, yeah. All the internal ones I prefer vicryl. On the surface, if I'm using skin grafts, I use Prolene, because when you're removing a Prolene, it doesn't bother the skin graft. There's no tissue drag when you remove a Prolene suture. So if I'm doing grafts, I use Prolene on the skin. If it's a kid where I'm supposed to leave them alone, then I'll use vicryl.
Okay, Milan, I want to ask you another question about your last case of sebaceous gland cell carcinoma, the one,
yes,
the terrible one.
Yeah.
If I were in your place, I would exenterate, because I feel that safety margin is not achievable because it's adherent to the globe. But I respect your choice. Can you tell me what do you feel?
I agree with you, because our first choice in that case was exenteration too. And another midline option for the patient was to do a primary chemo reduction, reduce the tumor, and then do a reconstruction. But the patient was absolutely not ready to lose the eye because he perceived that to be a normal eye. He was willing to take any risk of recurrence and a future exenteration, but he wanted us to try that out first.
Yeah.
So that's why we went ahead with it. And after that, he's been on follow-up for systemic spread. He also received radiation in that area.
Yeah, thank you.
There is another question in the chat for Dr. Samer.
Yes, please.
Can you read the chat?
Do you prefer to move intra-orbital glass foreign body or not, especially if it has tendency to migrate? Is this the question, Tariq?
Yes, yes.
Well, in fact, I would love, if I'm doing the primary repair, I would love to remove as much glass fragments as possible for many reasons. the most important reason is to make the family happy, that you have removed the foreign material and you did not keep anything inside. But practically, glass is an inert material. If it is a deep-seated fragment and it's not palpable, I would feel leaving it alone might be wiser than trying to manipulate and injure. I have seen people, patients who had serious injury by people trying to remove such inert materials. That's my the way I work, in fact. What do you feel, Miland?
Yeah, I agree. I mean, if my surgery is going to do more trauma than the foreign body, then I don't want to remove it.
All right, thank you.
Okay, there's two participants raise hand.
2%?
Two person who's yes, one.
دكتور عمرو حماد اتفضل. We unmute now Dr. Amra Hamad for his comment or question. Dr. Amra Hamad now.
Yes, my voice clear now?
Yes,
Yes.
clear.
I saw for the case for Dr. Milan, you prefer to use a Berlin suture with locked type. You prefer this type or interrupted? This is first question. Second question related to for flow fracture. What is the best type of support you put? You put mid-bore. What is the type of mesh? The best type you use?
So the floor fracture question is for Dr. Samir?
For the support for the tissues after repairing of the.
Okay.
What do you prefer,
Your first question was about the
related to the type of suture. You use interlocked locked suture.
No, for skin grafts, I prefer intermittent suture because the compression zones are placed in such a way that there is blood supply coming from the lateral edges. If you use a continuous interlocking, then you're actually blocking the blood supply that comes from the edge of the graft. So I prefer intermittent ones. It's also easier to remove that.
But I noticed that your case for the reconstruction, lower reconstruction, glabellar flap, you are using the interlocked Berlin suture in this one.
Well, if it's a flap, yes. But if I'm doing a skin graft, then I would prefer intermittent.
What's the best type of material you are using in orbital floor fracture?
Floor, as I mentioned to Samir earlier, it depends on what is the affordability of the patient. If I've just released an entrap muscle and the hole in the floor is very small, I sometimes don't do anything and the patient doesn't have enophthalmos. But if the defect is large, it's likely to lead to an enophthalmos. Titanium or a Porex sheet or even an X-ray plate in cases, or a sheet of PMMA, thin sheet of PMMA in cases where the patient cannot afford much and we want to do it in a small price package.
Can I comment, Milan?
Yes, Samir.
Yes, thank you. You know, sometimes in life, you learn things in a retrospective way. You get, exactly. You get a patient who was in the ICU forgotten for many months. Yes. And you imagine, you look at his primary CT scans, you say, oh, I would have operated on him for sure if they consulted me. But Absolutely. For 6 months, they forgot him. And when he comes to you walking, he doesn't have double vision. He doesn't have enophthalmos.
Absolutely, I agree with you.
So my point is, there is no black and white sometimes in the orbital floor fractures. So many times we are enthusiastic surgeons. As you mentioned, if you just release the entrapped tissue and place anything like Surgicel, let's say, or gel foam, and leave it, the things will be perfectly fine.
Absolutely.
Yeah, we don't, I mean, like in talking about evisceration, we have been running for ages after this. integrable materials, porous materials. We have paid thousands and millions as poor nations for the integrable mid-pores and doxapatite. And then you discover that it's, in fact, it does nothing much better than silicone ball, other than in, for example, primary inoculation when you want to suture the muscle to the ball, for example. What do you feel, Milan?
I agree that sometimes, I mean, many a times, nature does a better job than a surgeon.
Yes.
Sometimes we come in the way of healing.
Absolutely. Absolutely. That's true. What about your feedback about these porous implants? I mean, at certain ages, we were crazy that every patient should have a mid-pore or a doxapatite implant.
Right. I feel that orbital implants have followed their history track like fashion. And they come into fashion and then they go away. But what has stood the time of fashion, which in Indian culture, we call it the sari, you know, the dress which has always prevailed, is the PMMA or the silicone implant. I believe in that, and I don't use Porex anymore.
Yeah. All right, great.
I have one paper sent you, Dr. Samer, for comparison between Burras and silicone.
I will read it. I will read it thoroughly. Yes.
For 300 cases, there is no difference between Burras and silicone for eye exposed.
Before we conclude, Milan, I want to tell you and to tell my colleagues here. I was in the army. I was a military. I was a colonel. I'm tired. When I was a first year resident, one of my big bosses was really mad. He would shout on us. He would shout on the patient. He would shout on the specialists, on everybody. He was a very tough and aggressive man. He kept getting ranks. Then he became the most important man in the military medical field. Mm-hmm. I noticed that he's cooling down. That aggressive man has really given it an ease. And when he got retired, we went to his office on that same day to say, goodbye, sir. You have done a great job. We wanted to back him up. I told him, sir, I want to ask you, when I was a very junior doctor with you, you were mad with us. When you became a very big general, you were very cool. How did this happen? He told me, listen, my son, as we grow old, the number of ganglion cells in our brain gets lower and lower, but the connection between them improves. So this is my message, that we should always think in the 3 dimension in treating every patient.
I agree. Thank you so much, Samer.
Thank you. Tariq, I think it's about to conclude, maybe.
Yes, one question for Dr. Marwan. It's better to leave foreign body for 6 months. It's easier to find and remove it.
No, I don't think so. Foreign body either needs removal or doesn't need removal. If it's a vegetable origin, if it is something which might give you trouble, you should, once the orbit is settled, you should go after it. If with time it starts migrating and coming out and coming close to you, you can, yes, go ahead and remove it later on. That's what I feel.
Okay. Okay, and conclude. Thank you, Dr. Milan. Thank you, Dr. Samer.
Thank you, Tariq.
For organizing such a beautiful meeting and for letting me know such a wonderful surgeon like Milan.
My pleasure.
Thank you.
My pleasure, Samir. We'll meet sometime soon.
This is one of the. Yes, right. Thank you for all. Thank you for participants. We see you next week, inshallah.
Inshallah. Take care. Bye now.
Thank you.